Welcome back, everyone. I hope each of you took advantage of our short break. I'm going to hand it over to our chair, Dr. Kumthekar, to introduce our next session and each of our panelists.
Great. Thanks so much, Emily. So I'm really excited for our next session. It's a panel of speakers, and it's titled Navigating the Complex World of Clinical Trials. So this is, again, a multidisciplinary panel that will review the landscape of clinical trials, the logistics on how to get into this studies, and what to keep in mind just as patients and care partners. So the goal is kind of a broader overview of clinical trials and navigating the world, more than it is kind of about specific sciences. So the way that the session will work is that we'll start with a brief overview slide set that our panelists have put together, that they'll sort of tag team their way through. And then that'll be followed by an audience question and answer period. So with that, it is my pleasure to introduce you to our panelists. We have Dr. Ashley Ghiaseddin, who's an associate professor of neuro-oncology at the University of Florida. We also have Dr. Ayal Aizer, who's the director of brain radiation oncology at the Dana-Farber Cancer Institute and the Brigham and Women's Hospital, an associate professor at Harvard Medical School. We have Dr. Seema Nagpal, who's a clinical associate professor of neurology at Stanford. She's a neuro-oncologist that specializes in brain metastases. And Dr. Fauzia Riaz, who is a clinical assistant professor of medicine at Stanford University, who is a breast cancer specialist. So I'm really excited to have this broad and diverse panel that have all really contributed so much to the brain mets world and all participate in clinical trials as well as cancer care for brain mets patients. So please, would really love to welcome our panelists at this point. Can start the formal talk, and then we'll get into the Q&A.
Hi, everyone. My name is Ashley Ghiaseddin. I want to thank Dr. Kumthekar, Ms. Lippert, and the ABTA for inviting me to come and give this, be a part of the panel discussion. For my portion, I wanted to just make sure we cover our way of learning the dynamic nature about clinical trials in brain metastasis, and also learning about how brain metastasis fit into clinical trial landscape, both with dedicated CNS studies and studies that allow brain metastasis. Next slide. These are my disclosures and support. And just to kind of kick off what we're talking about and why this is so important for us to consider clinical trials for patients with brain metastasis. Each year, over 200,000 patients living with cancer are diagnosed with brain metastasis. And the incidence is increasing in those patients who have had lung cancer, breast cancer, and melanoma. Next slide. Historically, patients with brain metastasis were not enrolled in clinical trials. And there were several reasons, some factors that were considered in this. We thought of functional status. So looking at patients not being able to maybe take care of their activities of daily living because of their neurologic symptoms. There were concerns for difficulty for trials to actually assess the efficacy of those treatments for both systemic and brain response because of the difference that may occur with drug delivery. We have the blood-brain barrier that doesn't allow certain size of treatment to actually get into the CNS, central nervous system, as well as the pharmacokinetics with medications for patients when you're trying to treat patients who have brain disease. And there was always this concern for the potential of brain toxicity. We've studied this drug in maybe the systemic cancer space, but how is this going to affect the brain? These concerns have not really proven to be valid, though. Patients with brain mets have been able to tolerate treatment very well as achieving meaningful quality of life. And I would highlight the benefits that we've had for patients, specifically melanoma brain metastasis, where patients are living long lives and are doing very well. And I think that has kind of been a test case for showing that we can treat patients effectively when they have brain metastasis and give them their lives back so that they can go on to have productive lives and meaningful lives. Trials have also limited eligibility for patients with treated or stable brain metastasis. And that is really can be problematic because you look at a patient population that's being evaluated that may not represent the eventual patient that actually receives that treatment. So when you look at patients who are doing very well with regards to their brain metastasis and include them into clinical trials, you may not really understand what the results are going to be for those patients that may be having a brain metastasis that has now progressed and we're trying to affect their treatment, or if they have leptomeningeal spread and you want to affect their treatment. So those things have to be considered when you're planning a clinical trial. And then there's also the concerns that when you translate those treatments into the real world population, how is that going to actually translate? Because traditionally, when you look at clinical trials, because of sometimes the restrictive nature of their inclusion and exclusion, you may have a population that unfortunately may be doing better than what we see in the real world. And that can sometimes affect your results. And we need to be able to consider that when we're designing clinical trials and making sure we're inclusive of all the patients who are dealing with a certain disease, such as brain metastasis, so we can really understand how that's going to benefit them. Next slide. Just remember, this is a journey. So when you think of the pathway to clinical trials, it always starts with the diagnosis. That will be made in your physician's office, where you have a conversation talking about what's happening with your specific cancer, what are the changes, reviewing imaging, potentially pathology results. And this may lead then to a referral where your physician or care team is then going to either have a clinical trial available within your institution, or maybe even recommending a different institution that may have that study. This is where, some of the importance lies with, also patients and family being able to obtain information, doing their own research, looking at things such as clinicaltrials.gov, or if you're thinking of a particular institution, then maybe reviewing online what is entailed within the specific study. There's a pre-screening process that occurs as well, where there's an initial review of medical records, as well as a dialogue that will occur between a patient and the family, with also the research coordinator for a specific study at an institution. And there may be some ongoing discussion that asks about treatments that a patient has received, where their care has occurred, and getting some of the records that is necessary to kind of go through the process of determining whether or not a patient may be a good candidate for a study. We then kind of look at informed consent. This is where patients review and sign the informed consent, which is your voluntary participation to be in the study. And you always have that right to withdraw at any time. You have to review what the purpose of the study is. They need to discuss with you risks and benefit of the treatments, the study visits that are entailed. So if you're someone that is maybe far away from the center that's having the clinical trial, understanding how often do I have to come in? Are there telemed visits that are allowed? Do I need to come in for the drug, or is this something that I can take at home? What is the lab tests that are involved? So you understand the commitment that's needed to be in the specific study, and then also reviewing confidentiality. There's a screening process that will then occur where a patient may undergo specific tests, imaging evaluations to determine the eligibility for the specific study that's being considered. Patients must pass that screening to proceed. And then depending on the trial that you're in, some are single-arm studies, and I know that my fellow panelists will review this in further detail, but if there's a randomized control study, that's where the randomization may occur, where a patient is assigned to one of multiple groups, where there could be active treatment, there could be a control arm where a patient may receive placebo or standard of care. And then finally, the patient is able to participate in the trial and followed very closely by the study team. And there's a seamless interface between the research team and the clinical team to make sure that patients are receiving the highest value care possible. Next slide. Another question that may come up to people is when do we screen for brain metastasis? And this is a complicated question to answer. I think it's easiest to say when someone has a known history of brain metastasis, imaging may occur every 2 to 3 months for close surveillance. That may be sooner, could be 4 to 6 weeks if there's a change under question. We see something on the scan, but we're not sure, could this be tumor growth? Could it be treatment effect? Could it be changes related to the drug that's being given? Is it immunotherapy? We think that there's potentially immune changes that are occurring. And then certain cancers, there's high risk of brain metastasis, and that may allow for early intervention, clinical trials, or stereotactic radiosurgery when lesions could be small enough. And then also if a specific study has inclusion criteria with concerns related to brain metastasis, that may be a reason for imaging. Or if the study objective is to evaluate the effectiveness of an intervention on the central nervous system. But in summary, the frequency and whether or not patients are going to be screened for brain metastasis will ultimately come down to the type of primary cancer a patient may have, as well as presence or absence of neurologic symptoms and the clinical trial for someone is being considered for. Thank you.
Great, and we'll hand it over now to Dr. Aizer.
Okay, so that was a wonderful introduction, and thank you so much, Dr. Ghiaseddin, for setting the stage for today's talk and panel discussion. Also wanted to thank the organizers and the ABTA for inviting me to give this talk and participate in this panel. Feel really honored to be with you all today. So I will be giving a little bit of an overview on clinical trials and talking a little bit more about process and phases. And we can transition to the next slide. These are my potential conflicts of interest. Next slide. So I think as we've been hearing today, the main purpose of clinical trials is to develop and improve the management of patients who either have or who are at risk for a given condition. And it's really important to re-emphasize that almost everything we do today in medicine is done because of prior trials. So trials really are the most important driver of change in the way we practice medicine. And there are many types of clinical trials. I think most of us are acclimatized to thinking about treatment trials. Is a new drug safe? Is a new device or radiation delivery mechanism better than a prior one? How do these new and novel therapies compare to the standard of care? Questions focused on treatment. But there are other types of trials, including screening trials, meaning looking for cancer, or in this case, brain metastases in populations that necessarily aren't always screened. For example, at our institution, we have a trial to screen patients with breast cancer for brain involvement, because traditionally brain MRIs have not been part of the screening or follow-up regimens for patients with breast cancer who don't have brain metastases already. There are prevention trials. Can we prevent a certain condition from occurring using a new approach? And then there are trials that are focused a little bit more on quality of life or natural history among patients with a given condition. Next slide, please. So the appeal of trials is that they allow patients in need, and in need can be broadly defined as, where the standard of care may be insufficient, to receive promising but unproven new treatments or preventative strategies or diagnostic studies. One of the benefits of being on a clinical trial is that a patient can get early access to a potentially helpful new strategy. Patients on trials are typically monitored more closely than patients who are not on a trial. There tend to be more eyes looking at those patients, and those visits or scans or what have you are typically occurring more frequently, often because a new approach is being tested. So that can be beneficial for patients because other issues that patients develop may be attended to because of all the extra attention that being on a trial can impart. And in addition to potential benefit for patients on trials, these trials advance the field for the betterment of other patients. So trials have appeal in many different domains, but there are certainly risks. And those include that a given trial therapy or strategy may be ineffective. And not only could it be ineffective, but it could be detrimental to care. There could be unanticipated side effects or problems that occur as part of being on a study that prevent other therapies from being given for a while, or that cause direct toxicities. And in addition, trials generally require more visits or more interaction with medical personnel. And there may be time lost from work, there may be time lost from family, and there could be some cost. Some studies reimburse for cost, others do not reimburse as much for cost. But there are real potential downsides to trials too. Next slide, please. So we heard about the process just a few minutes ago, so I won't reiterate what already has been said. I'll just make one point here and say that, when it comes to a clinical trial, whether it's enrolling in that trial or how long to remain in the trial, or how the trial is going from a patient standpoint, we really do want the patient to be in the driver's seat. Obviously these trials are testing new therapies and approaches or strategies that are generally not proven or yet the standard of care. So especially when it comes to signing up for a study, I often view my job as to really present the information, the rationale for the study, as much as we can determine about risks, benefits, and what's involved. And then really allow the patient to make the decision that they feel is best for them. And, if a patient ever decides that they do not wish to be a part of a study anymore, then that's also a patient's prerogative. Now, we always would encourage discussion with medical personnel because there may be some, consequences for doing so, meaning potentially stopping an effective therapy or not being able to, get a new intervention of another sort. But, we really want the patient to be in the driver's seat and us to be guiding forces for patients when it comes to clinical trials. Next slide. So there are multiple phases of trials, ranging from 1 through 4, and we'll look at these in the next couple slides. Phase 1 is really about determining if a new strategy is safe and what the optimal dose is for, let's say, a new drug from a safety standpoint. Phase 2 is about once the dose has been determined or the preliminary safety of a strategy has been ascertained, is there a sense that this new approach is helpful? Not the end-all be-all determination, but is there a general sense that a new strategy can be beneficial for patients? And if so, then a new strategy or drug or treatment or approach will move to phase 3 typically, where it's compared against the current standard of care in a head-to-head comparison, which we'll look at. And then after approval, sometimes there are phase 4 studies which look at how does a new approach fare in the real world over time at many centers in a diverse patient population. And that's sometimes called a phase 4 study. Next slide, please. So phase 1 is the earliest of studies. In a phase 1 study, the goal is just to determine that a new approach is safe and perhaps to determine the most safe dose that can be used for a given intervention. These are typically relatively small studies. often 30 patients or fewer. Typically, everybody gets the new treatment, but the dosage might vary. And these studies can sometimes include window of opportunity studies where patients are getting a novel drug or treatment prior to anti-cancer therapy, which is often surgery. So in the brain metastasis population, perhaps a novel drug is given and the determination is made, is there penetration into the brain before a standard of care craniotomy is performed in a patient who would be going to surgery anyway. In phase 2, we're really looking for a signal for efficacy. These tend to be larger than phase 1, but smaller than phase 2. They vary in size pretty substantially, but in the brain metastasis population, sometimes they're around 50 or 100 patients. They may be non-randomized, where everybody gets the new treatment or approach, or they could be randomized, where some patients get the new approach and others get the standard of care. And I think patients sometimes think that, when we do a randomized study, we're choosing the best treatment for them, or we have a computer or AI algorithm that's choosing the best treatment for them. And although rarely there could be some studies that prioritize effective treatments over less effective treatments, most traditional randomized studies are determined, truly randomly. It's like flipping a coin, and if the coin lands on heads, treatment A is given. If the coin lands on tails, treatment B is given. Next slide, please. After phase 2 comes phase 3. If the study or approach is positive or promising, and this is a true efficacy or effectiveness study. These are often larger multi-institutional studies. In other disease entities, they can be thousands of patients. In the brain metastasis population, they tend to be smaller, often more than 100 patients, but often not in the thousands of patients, typically a few hundred patients. These are typically randomized because you are trying to prove that a therapy is definitively better than the standard of care. And they may be blinded. And what blinded means is that either patients, the trial team, or both is not aware of what treatment or approach is being given. And these are the studies that ultimately can result in FDA approval of a new approach. After phase 3 can be a phase 4 study, which we've touched on earlier, which is how does the new approach fare in the real world over time in many people. And then some studies can be combination studies like phase 1, phase 2, phase 2, phase 3. And, in an example, phase 1, phase 2, maybe you find the optimal dose in phase 1 and you move on to phase 2 to test that dose for preliminary efficacy. Can I have the next slide? So just a couple examples of some studies that were published in recent years that, really impacted the field dramatically. This is the Checkmate 204 study. This looked at ipilimumab and nivolumab combination immune therapy in melanoma with brain metastases. And this was the cohort who were asymptomatic or not on steroids. This was a profound improvement from the standard of care and had an almost immediate impact, even as a phase 2 study, because patients who had historically had a less than optimal prognosis were, achieving intracranial disease control and long-term survival rates at percentages that had never been seen before. Next slide. This was a randomized phase 3 study. So this was the CC001 study. This compared traditional whole brain radiation to hippocampal sparing whole brain radiation in the management of patients with brain metastases. So this looked at whether a novel form of radiation could prevent cognitive decline or minimize cognitive decline in patients with brain metastases. And this was a positive study showing that sparing the hippocampi from the radiation field minimizes the risk of cognitive impact from the radiation. And that is my last slide. So I'll look forward to the panel discussion shortly. Thank you all.
Thanks so much, Dr. Aizer. We'll hand it over now for the finale of the slides here to Dr. Nagpal from Stanford.
All right. Well, Dr. Nagpal is actually in Istanbul right now. So thank you for having me and understanding that I am totally jet lagged, but happy to be here because I think this is so important for everyone to learn about. So I'm going to speak a little bit about learning institutional specifics, but really to get into the nitty gritty of how we use clinicaltrials.gov, primarily because everyone talks about it and everyone says this is really hard to use, but we don't know what it looks like. So next slide, please. So how do you find a clinical trial for brain mets? Like in the real world, most of the time you're going to be referred by your primary oncologist, your radiation oncologist, or your neurosurgeon. Why did I leave myself off and Dr. Kumthekar? Because we're rare. Neuro-oncologists are a very, very small slice of oncologists, and most patients don't have us. So you're going to be referred by the folks who are biased by their tool. And what do I mean by that? Well, when you have a hammer, everything is a nail. So oncologists love to use chemotherapy, the radiation oncologists like to use the laser beams, and neurosurgeons like to cut. So keeping this all in mind, we're going to figure out how to look at trials that are best for you. The first place to look is often the cancer treatment website for your institution. My institution, Stanford, has a nice one and it is pretty up to date. I have to say that's not true for every place, but that's often a good place to start. Clinicaltrials.gov, which I'm going to show you a few slides of soon. There actually are private trial navigation companies that can help you call all of the folks that you see on the screen today and their trial coordinators to figure out what's best for you. And then patient organizations like the ABTA and the National Brain Tumor Society also have ways to navigate clinical trials. Next slide, please. All right, so here is the website. This is actually pretty recent. And I'm going to tell you that when I typed in clinicaltrials.gov, I actually got a warning that I was going to be taken to a beta test. So I'm going to be giving you the old site, and there's a new site coming. So on the left side is what you're going to see when you log in now. And on the right side is a brand new way of getting search results. On the left side, you're going to see in very small print, I apologize, condition or disease, other terms, and country. So condition or disease for what we're talking about is going to be brain metastases, and it might be breast cancer, lung cancer, non-small cell, melanoma for your other terms to make sure that we're getting to exactly your disease. Or you might want to keep it broad because some trials are actually, especially radiation or surgical trials, that we're going to take all those different disease types and lump them into the same study. On the right-hand side, you'll see what happens when I put in brain metastases on lung cancer. I actually got 294 studies. Not super helpful. That's a lot of homework to do for you, right? Okay, next slide, please. Why is this difficult to navigate? Well, clinicaltrials.gov gives you the old trials and the new trials. So looking carefully here, I circled in red. This one actually says completed. So yes, it's a study. And in fact, there are results and you could click to get the results, but so those 294 studies, not as many as we think, right? There's just, this one's already done. Can't participate. Next study, please, or next slide. This one is brand spanking new. In fact, it's so brand spanking new that it is active, but it's not recruiting. That means either some sites have opened and there's no slots, or it means that it's active, all the slots are gone and you can't participate. So again, kind of a less than helpful result, right? So this is number 3 of 294 results. Next slide, please. There are trials that are going to be close to you and many, many, many trials that are far, far away. Hopefully not as far as Istanbul, but this one that I circled is in Milan, Italy. And I don't think most of us are in Milan, Italy today. Why is that important? Clinical trial participation is a time commitment. And while Milan sounds really awesome and fun right now, it may not be fun if you have to spend days, weeks, or even months in a place where you have no friends, no family, and no support. It can be quite costly. So it's important to think about it and take note of where the trial is taking place. Next slide, please. So there is a sidebar on the new clinicaltrials.gov site. And it says, focus your search, and gives you lots of choices. I will say you got to spell correctly to get this right, but brain metastases, lung cancer, male or female, you select your age range. Most of us are not looking for children, but you just keep them all if you want. And then you can actually focus your search based on study phase, early phase, which is usually even earlier than safety. It might be phase 0. What does phase 0 mean? Phase 0 means we give you the drug, we do a surgery on your brain metastasis, we see if the drug is actually in there. And that's the outcome of the phase 0. So that's what early phase might mean. And then you have all the phases, phase 1, 2, 3, 4, and then doesn't matter, right? Not applicable. Study types, interventional. What does that mean? Interventional means we're doing something, we're providing something for you, a drug, a device, a surgery, a new radiation technique. Observational means we're probably doing something we already know how to do, and then we're watching to see how things work out. So that patient registries underneath that means that you would be registered to be followed, but not necessarily to get anything new. And expanded access may mean, hey, we know this drug works, it's going towards the FDA, but it's not commercially available yet. So there's a lot of really interesting terms in here that take practice using, and as Dr. Brastianos mentioned in her talk, really speaking with your oncologist to understand what the heck they mean. Because unless you practice, it's really tough to do this right in the moment. Next slide, please. And why is it so important? Well, you got to read the details as well. So, okay, we used our sidebar. Maybe we got down, instead of 294, maybe we got down to 30 trials that are interesting to you. So do you fit? Many trials have age restrictions. 18 and older is pretty common for brain metastases. But deep in there is, how able are you? So are you cooking for yourself? Are you doing your own bills? How well are you speaking with other people and communicating? These are important things, because often these studies will have a cutoff of a Karnofsky performance score, which is kind of talking about those things, or an ECOG score. Same idea. How able are you? And there's often some exclusions and inclusions about what treatment you have or haven't already had. So for example, if you have non-small cell lung cancer and you have an EGFR mutation, if you have not had osimertinib/Tagrisso yet, many studies are going to leave you out. Now, why is that? Because OC is a good drug. You should have it first before we try an experiment on your brain. And we're also going to ask questions like, has your bone marrow recovered? Do you have enough platelets to handle this new therapy? Do you have enough white cells to handle the new therapy? Next slide, please. All right, so that's a lot of nitty gritty about what you're going to see on clinicaltrials.gov. You're also going to see the centers that are running the studies. And what do you need to know about them? Not a ton, to be honest, but you need to know with what you're comfortable with. So there are many types of cancer centers. NCI designated cancer centers in the United States are basically designated sort of by the NIH and the National Cancer Institute as meeting certain bars and levels of what their trials do, how many patients they see, the diversity of the folks included on clinical trials. Most of those are academic medical centers. And what do I mean by that? They're connected to a university. There might be a teaching hospital, but not all of them are. There are satellite academic centers. So that means, for example, if Stanford has big Stanford in Palo Alto, if we have a site in Emeryville, that's not actually in Palo Alto, right? That's somewhere else. That's a satellite center. It might be smaller and it might not be capable of running, frankly, it might not be able to run brain met studies because it's a satellite and it's a small population. But Dr. Riaz might tell us some of our satellite centers are running breast cancer trials. Is that correct, Dr. Riaz? I'm going to wait for you to answer because I know you're on.
Yes, that is correct. So just like you said, some of the satellite sites are equipped to run trials. Some are not quite there yet, just because they don't have the same infrastructure as the central main site.
Exactly. And that's especially true for brain mets, that you have to kind of be a little bit aware of that if you're in phase 1 or phase 2. Now, if you're in phase 3, it is quite possible that a satellite academic center is going to have the capacity to run that study. Comprehensive cancer centers, big cancer centers, but may not be attached to an academic center. Community-based programs like Texas Oncology, also huge networks, tons of doctors, but may not be running the phase 0s or the phase 1s. Sometimes they are. Less likely to have a dedicated neuro-oncologist, but might have a breast cancer oncologist or a non-small cell oncologist who's super duper interested in brain mets, right? So it doesn't mean they won't have a study, it just means they might not have me or Dr. Kumthekar specifically. And then there are freestanding oncology programs, and those are often known as community practices. They're less likely to have a brain met study, but again, if included in a phase 3, it's possible they might. Larger centers may have more subspecialized MDs and trials, but they're also harder to get to often. So for example, parking at our institution is not often the easiest. Same with our big brother up the street, UCSF. In bigger cities can just be less accessible than some of the comprehensive cancer centers or other places. So just because it's not an academic center doesn't mean it's not the right fit for you. Private institutions like my institution, for example, can have different insurance structures and requirements than public institutions. So that's also important to consider when you're thinking about a trial. In California specifically, insurance is supposed to cover clinical trial access at any institution, but it can still really be a major barrier. I know, Dr. Riaz, have you found that to be true for you as well?
Absolutely. Yeah.
So we're working on it. I can't say that we're in control of it, but we all wish that everyone had access to all of our studies. Next. Yeah. So that being said, you guys have seen a ton of variables that we look at when we're looking at clinical trials. So there's no right clinical trial, to be perfectly honest. And you're going to find many people find this frustrating when I give them a menu instead of telling them to go on which one. Why is that? Well, because it's an experiment and I don't know the answer. If I knew the answer, I would tell you the answer, and I don't know it. So there's not a right answer. And it's really about what's right for me. Can I travel to that? Do I have interest in being phase 0, where we really know very little about this drug, or do I really want phase 3? There's little data to guide or influence decisions, to be honest. And I think about it practically in the end. Are there toxicities that I'm not willing to experience? So let's say in a phase 2 drug, we already know that diarrhea is the toxicity. If I am a person who cannot do that, and maybe I'm already in a wheelchair, like diarrhea is a bad idea, right? That's probably not the best study. So thinking about that a little bit in advance, are there limits to the amount of time I'm willing to spend participating? Early phase studies, you're going to spend a lot of time with me, like a lot, like maybe 8 hours in a day on your first drug dose day. That's a long time. So thinking about those things. Does this trial limit my future option for treatments? For brain metastases, that's less likely, but it can happen. Is a trial at home, or do you have to travel really far? Is there a chance I'm going to get a placebo? Is this a targeted therapy? Is it specific to me, or is this something that is sort of general or broad? And what am I actually interested in as a patient learning? Next slide, please. So we talked a lot about travel. This will likely be available to you in a slide format, but there are lots of ways to get additional resources if it feels daunting. I do think it's still important to think about, because it's no fun to travel by yourself, I think. Probably want to go to a place where you have friends or family, but these are other ways to do it if the pocketbook expense is going to be tough. Next slide, please. Okay, so knowing all of these things that I've heard from all of us, do I have to participate in a clinical trial? Next slide, please. Answer is no. Okay, and I think that's probably the most important thing we can tell you today. We've hyped it up a lot. We think it's really important. That's how the next new cool thing is found, but ultimately it might not be for you, and that's okay. Next slide. Participating in a clinical trial is a choice. It is voluntary. And even if you decide to start, you can stop at any time. I never hold it against my patients. I always tell them that their care comes first, and I will take an FDA spanking if I need to, so that they can do the right thing. You should never feel pressured to participate, not even by me or any other of your physicians, because it doesn't negatively impact me if you don't participate. Clinical trials are definitely not the right choice for everyone, and that is okay. And if it is, we're ecstatic that you're willing to participate. Next slide. I think that might be my last one. It is just disclaimers.
Awesome. Thank you all so much. It was such valuable information that you're sharing with us on navigating the complexities of clinical trials. I think we have time now for questions. Breen, do you have the question?
Yeah, Dr. Kumthekar, if you want to start with any questions for the panelists, then I'm happy to jump in with questions that we have from our audience.
Yeah, maybe let's start there first, just so that we have time to get the audience questions prioritized.
All right, so just as a reminder for our audience, if you do have questions that you want to ask, please type and submit it using the Q&A button, and we'll answer questions as time allows. So one of the first questions we have here goes back to Dr. Ghiaseddin, your presentation. You had talked about how trials have limited eligibility. Aside from the diagnosis, what are some factors that may limit a patient's eligibility from entering a trial?
Thank you for the question. And it really is variable depending on what the study is looking at, but many times they will look at potentially number of brain metastases. They may look at the primary cancer that's being studied. So there are some studies that are agnostic to the disease, saying that whether you have a primary breast cancer or lung cancer or melanoma, pituitary, it's okay, you are welcome to participate. And others may be more specific because they're looking at a marker that may only be actionable for a particular type of cancer, like a non-small cell lung cancer, where they're looking at a specific marker for that. Others also want to concentrate potentially on patients that have failed their initial therapy for brain metastasis. So they're looking at those who have maybe failed the initial treatment, whether that was stereotactic radiosurgery or some other targeted option, and now want to investigate something else. Because Dr. Nagpal so eloquently put that if you have a treatment option for brain metastasis that actually is working, they don't want you to go on a clinical trial just yet, because you may have an option that will work very well for you and you don't need to proceed further. So I think those are potentially times where there is importance in making sure that patients meet those requirements. There's also those requirements that want to know, how well you're able to tolerate that therapy. And that's where we ask, how able are you? Are you doing the normal activities of your daily living, where that may be, can you cook for yourself? Can you change your clothes for yourself? Or do you need just a little bit of assistance? And that may be okay, but they want to make sure that when we put a patient on study where we're not really sure what the side effects could be, we don't want to make things worse. And that's how we try to minimize those risks as well.
Thank you so much for that insight. Kind of a follow-up to that. Are there ever any circumstances where a patient that doesn't meet the eligibility requirements can join a clinical trial, something like compassionate care?
I can start, and if others have insight, that's would be helpful to know. I would say that within a context of a specific clinical trial, they have those inclusion criteria, exclusion criteria, and it's pretty strict. I don't think that really allows for flexibility for someone to be enrolled that doesn't meet those requirements. When you think of the expanded access or compassionate use type of programs, that's where there may be some allowance because it's been studied and we feel like this is going to work. It's going through the process of being approved. We just don't have a commercially available product yet, but we are a place that actually has this treatment. Then you may need to actually submit a what we call N of 1 study or expanded access program, where you're writing the protocol specifically for that patient, that may allow for some more flexibility in that time. If we're looking just at that particular trial that's being run, they have those safeguards in place for a reason, and I have not seen instances where you're able to be flexible with that.
Thank you so much for sharing your insight with that. Another question we have here is asking, is it the patient's responsibility to do the research to bring up clinical trial options, or is there someone on the care team that is kind of spearheading that? Dr. Riaz, as a medical oncologist, do you want to maybe start us off with that question?
Sure. So what I will say is, I imagine this varies from place to place and institution to institution, what sort of infrastructure exists to recognize patients who are eligible for specific trials. And as a breast oncologist, it's actually something I'm constantly thinking about for my patients. And what I encourage actually my patients to do is to be curious and to actually ask their doctor. I often will see second opinions. And what I say is, well, if at any point your doctor wants to change your treatment, well, ask them, hey, is there a trial available for me? I always encourage them, you can always reach out to me and ask if we have any trials available to you. So I think it goes both ways. It's, I encourage my patients to be curious and to ask. But like Dr. Nagpal showed in her slides, I mean, finding trials can be tough, and you have your clinical team should be your partner in this. So that's what I would encourage.
Thank you so much, Dr. Riaz, for that insight. Another question we have, this one I'm going to direct to you, Dr. Aizer. You had shared that wonderful graphic showing the different phases of clinical trials. How long does it take a clinical trial to move through these different phases?
It's a great question. And, the sad reality is that, not every drug or therapy will be able to move through all of those phases. There are, diminishing, I think in Dr. Nagpal's talk, you saw the numbers for phase 1, 2, 3. And, there was a drop off between 2 and 3 because sadly, some of the phase 2 therapies, for example, just don't work with a high enough degree of confidence that they move on to phase 3. But let's say a drug or treatment is really promising and it's moving through safety and prelim efficacy and then moving on to phase 3. It really varies quite substantially based on what intervention you're looking at, how many centers it's open at, how willing patients are to participate in the study. Even promising therapies sometimes have to be, the studies testing them either have to be delayed or even closed sometimes because accrual could be not what it was intended to be initially. But the hope is that we can move through these phases quickly for the benefit of our patients. People are looking at novel trial designs in a way to make them proceed more quickly. But generally, phase 1 and to some extent phase 2 tend to go more quickly because you're usually dealing with smaller numbers of patients and they're much less complicated because they're often at a limited number of centers, and you often have a group of highly motivated investigators running them. So, phase 3 can be a little bit more, a little slower because they're often multi-institutional. You often it takes months or even sometimes a year to open a study at a given center. It can take a really, really long time. But, I think our hope is that, we can shorten the time of these phases so that we can get promising therapies to our patients sooner. And that, what used to take, at least, in the radiation realm, a phase 3 study has often taken, 5, 6, 7, 8 years. We are seeing shorter timeframes now. And I think that's because of better awareness of trials, better presentations of trials to patients, and construction of more appealing trials and internal workflows that just work better. So, I think, unfortunately, it is a slow process, but one that's hopefully getting faster and faster.
Thank you so much for sharing that insight on the different phases of clinical trials. A follow-up question to that. Do patients receive updates on clinical trials that they've participated in, where it is now, if it's being submitted for FDA approval, anything like that?
I think I'll take that one. This is tricky, actually. So for some studies, the answer is yes. Patients do receive updates even from the study company. As a clinical trialist, I try really hard to keep in touch with my patients. And if there's a new update on the study, I will actually call them or tell them in clinic what's going on. In glioma, we actually had one of our first positive studies in many, many years just come out. And for those patients who had come off study, we did actually still call them and let them know what the updates were. So I think there's differences in how companies approach it and differences in how clinical trial groups approach this. My hope, though, is that we do all call our patients because we couldn't move forward without you.
Thank you so much, Dr. Nagpal, for that insight. Another question we have here is about the satellite academic centers. Dr. Nagpal, I think you had mentioned that some satellite centers may offer their own clinical trials. Do patients who are on trials at these satellite centers ever have to travel to the main academic medical center?
The hope is no, actually, right? That's the grand plan, but I'm gonna let Dr. Riaz answer because I saw her unmute too.
Yeah. So if a clinical trial is being opened at a satellite center, there is a lot of planning and a lot of, there's just a lot that goes into it. And yes, the goal is that they should not have to come to the main center because, again, the satellite center should be able to have all the necessary, services and needs that may be required by the patient through the trial. So we do have some of our breast cancer trials that have opened at our satellite centers. They tend to be a little bit, they don't tend to be those early phase trials, right? Because the level of care and monitoring that's necessary is just would not be feasible at a satellite center. So they tend to be a little more straightforward later phase studies to ensure that they can be done successfully.
Thank you so much. Kind of along that note, talking about travel, lodging that patients may need, what costs are covered by the clinical trial and what costs may be out of pocket? Dr. Nagpal, I think you highlighted some great resources to help with travel to and from treatment centers. And we know that cost, I think Dr. Ghiaseddin, you may have highlighted, it can be a big factor in limiting a patient's ability to participate in a clinical trial. So are there other financial assistance programs available for patients on trials? And are there any costs that trials take on behalf of the patient?
I can start. I think it depends on the clinical trial. So some of these studies that are funded by specific grants that may have patient travel expenses actually built into their study will allow for travel when there are patients who live outside of a specific radius, and specifically that would, usually entail someone who's living greater than an hour and a half or 2 hours from the institution. They'll allow travel grants, which could be mileage or transportation to and from, with stays that could be involved for how long the patient has to be there. And then it also comes down to, some of the resources that Dr. Nagpal had mentioned, where there are advocacy groups, grants that people can apply for. And that's where I think it's important for the center, when you have a social worker who's able to work with those patients and decide, how we can best advocate for them by applying to certain places. And the center itself may actually have a patient support fund that is there to help those in need. So it could be in the form of gas cards to allow them to be able to come in, or even a night stay, or, with working with the local vendors, hotels that have discounts provided for them, or Hope Lodge, or these sorts of resources that are available. So I think it depends on the study, but many centers also have a mechanism in place to try to help those patients as best possible.
Thank you so much for sharing your insight with that, Dr. Ghiaseddin. I think we have time maybe for one more question. This question is just asking, when looking into clinical trials and bringing it up as an option to your healthcare team, what are some of the most important questions you should be asking? And Dr. Nagpal, I think you highlighted some great questions. Maybe we can get some insight from some of our other panelists as well. Are there questions that your patients tend to ask, or any advice that you would share to a patient that's trying to better understand clinical trials and why they should participate?
Happy to start. I think the first thing to ask is, what is the standard of care? You're often looking at trials at times of transition, oftentimes where an existing therapy is stopped because it's not working, or because it's yielding toxicities that are too great. So what are the standard options? Like, if no trial existed in the world, what would you recommend? And I think that's often very, very helpful with knowing whether a trial would be important or not. Because, as was mentioned multiple times, if osimertinib has never been used before and a patient has EGFR mutant non-small cell, it would be very, very difficult to replace that, and nor should we replace that with a trial therapy. But maybe there would be a trial that added to osimertinib, but replacing it would be less optimal. So just understanding what the standard of care is very, very helpful. And then really dissecting, the rationale for the trial. Like, why is this trial being done? What phase is the trial in? What have prior results been with this trial agent or device or treatment? What are the safety data on it? What are the efficacy data? Like, how well has it worked in earlier studies? And even if it was a phase 1 study, you can sometimes read a little bit between the lines and say, like, well, there was a sense that maybe it helped at these higher doses, but we obviously don't know that for sure. And even that information may be a little bit helpful. In addition, I think you've heard many times just the logistics and what's involved and how many visits and cost and those are all really, really important factors to consider. And then, eligibility criteria. If I decide not to participate in the study now, is it an option for me in the future? And sometimes the answer is yes, and sometimes, sadly, the answer is not, because some trials will say it will allow X number of therapies before trial enrollment, and maybe this will be one too many if you don't pursue it at this time. So, understanding what the options are in the future. Also, where is the trial in terms of its accrual? If that's releasable information, are you going to be the third patient on the study, or has the study been open for 3 years? And that can also be helpful information.
Thank you so much, Dr. Aizer. Yes, Dr. Riaz, I see you're unmuted.
Yes, I mean, echoing everything Dr. Aizer said, I think the most important is, understanding what standard of care is and what your other options are, because, these are investigational therapies. One point I do want to emphasize, because oftentimes my patients, the fear is this is investigational, right? And so, all trials go through an institutional review board to ensure that it's not only something that to not only ensure we're using, an ethical approach, right? We've alluded to this example multiple times throughout this talk, but using osimertinib, making sure someone's had osimertinib, a very effective therapy, before, going on to certain experimental drugs in specific types of lung cancer. And so making sure that every measure of, and the other part of what the institutional review board does, that is to ensure that that all adequate measures of safety have been taken to ensure that the trial is as safe as possible for anyone who decides to go on it. So I do always like to bring that into the fold of the conversation.
Thank you so much. Unfortunately, that is all the time that we have for questions for this session. Thank you again, and I'm going to go ahead and turn it back to Emily.
Yes, thank you all so much for this excellent session. The conversation was really informative, and audience members, I hope you found it beneficial. And thank you so much for submitting your questions.